Welcome to the first part of this three-part webinar on insulin resistance, a functional approach to early detection and treatment. And this first part, part one, Foundations of Insulin Resistance, is going to be presented by Dr. Michael Kaplan. Dr. Kaplan is a graduate of Vassar University. He's one of our lab doctors here at Meridian Valley Lab, does a lot of consulting on insulin resistance and hormone panels and many other things, as well as having a private practice at the Toma Clinic in North Seattle. He's one of our smartest doctors. We're all smart here. And it's my pleasure to turn the webinar over to Dr. Kaplan now.
Thank you very much, Dr. Larson. It's really a pleasure to be with you here today. Thank you so much for sharing your morning or your afternoon or your evening, whatever the time may be where you are. One of the things that we all love to do here is to teach and give classes, and so it's really a privilege to share the next hour with you. I'm going to present some information for about 45 or 50 minutes, and then we'll save the last 10 to 15 minutes or so for questions. And I'll just address one quick question before we start. There's a question about getting a recording of the webinar. If you're not able to attend the whole event, yes, we will be very shortly after this broadcast be making this available on our website. And if you contact our marketing department, Mr. Chase Winteroff, we can tell you how to access that. Okay, without further ado, let's get started. So as my colleague Dr. Larson mentioned, today is part one, the foundations of insulin resistance. My job is going to be to set the table for part two, which is going to take place in 2 weeks. We're going to delve into the testing section of this module and talk about really the best way to test for insulin resistance and some recent innovations that we here at Meridian Valley Lab have been able to bring forth. And then 4 weeks from today is part three. My colleague Dr. Mi-Jung Lee will present the treatment section of our three-part webinar, and will essentially pay off on a lot of the foundations that we talk about today. She'll basically be talking about what do we do anyway with all of this. Okay, so let's get started. So I'm not going to spend a lot of time talking about type 2 diabetes. Type 2 diabetes is a known problem. It's on the rise. We're all aware of that. But we all are aware of the tremendous cost that impacts all of our communities. It's very much in the forefront of all of our minds. We're going to take a step sort of earlier in time and talk about the road to metabolic syndrome and prediabetes, and that's what we're going to call insulin resistance. But I did just want to share with you one statistic on type 2 diabetes itself that I found particularly sobering, and that is that here in the U.S., teens and tweens, which is the younger group below teenagers, has experienced a skyrocketing of prevalence of type 2 diabetes, over 35% between the years 2001 and 2009, which is really shocking. So diabetes, in some circles, we're just going to wait until the problem develops. No, that's not the approach we're going to take at all. We don't subscribe to that in functional medicine or in naturopathic medicine or any of those disciplines. So prediabetes, which we'll get into the definition of that in just a moment, is also on the rise. 50% here in the U.S. over the age of 65 have prediabetes, and of this group, over their lifetime, 70% will develop full-blown type 2 diabetes. Again, it sounds like it's a foregone conclusion, but we know that it's not a foregone conclusion. We can arrest this development. So the American Diabetes Association defines prediabetes as any one of these three criteria. Hemoglobin A1C between 5.7 and 6.4, as you can see. Fasting plasma glucose in this gray area, up between 100 and 125. And then a 2-hour oral glucose tolerance test, which unfortunately has many flaws, between 140 and 200. Here at Meridian Valley Lab, based on our experience looking at a lot of early tests for insulin resistance, which Dr. Larson will get into in the next webinar, we see a lot of problems developing at hemoglobin A1C of 5.7. So 5.7, in our view, is really not a comfortable place to be, even though it's not yet a red flag in a lot of communities. Okay, so how does metabolic syndrome relate to insulin resistance? Sometimes they're referred to as synonyms, but they're not quite synonyms. Insulin resistance is just an ingredient of metabolic syndrome, but as you can see, it's an important ingredient. It actually leads to central obesity, the atherogenic dyslipidemia, and endothelial dysfunction. So it's an ingredient, but it's also a cause. Very important one at that. So if we look just for a moment at metabolic syndrome, again, more sobering statistics. Over 40% of people in the U.S. meet the criteria, over the age of 60 meet the criteria. Children are becoming obese at triple the rate that they were back in the 1960s. So not a big surprise to anybody, but just wanting to lay this groundwork here. So for your notes, I'll leave this slide up for a moment. 5 criteria, which we're actually going to come back to a little bit later or at least I'll make reference to this later in the presentation. 5 criteria for metabolic syndrome. 3 out of the 5 will earn the person the Metabolic Syndrome Award. And you can take a look at the criteria here. For blood pressure, systolic over 130, diastolic over 85. I don't know about all of you, but this walks into my office all the time. So it's perhaps easier to achieve this than maybe some have realized. Okay, let's take a look at our fundamental pathway here. Just by way of review, want to just make mention of here all of the things that insulin stimulates under normal circumstances. So when insulin fits into its receptor site, it promotes the translocation of the glucose receptor to the cell membrane, and then glucose enters the cell. That insulin signal also stimulates glycogen synthesis. Think about metabolically being in the well-fed state. And then the insulin signal secondarily stimulates the generation of pyruvate in glycolysis. And then, of course, we can do fatty acid synthesis. And insulin, of course, responsible for all of those things. What I'd like to do in terms of the meat of my presentation today is to present to you 6 mechanisms or 6 theories, 6 lenses through which you can view the development of insulin resistance. And some of these are happening perhaps in isolation, but more often they're happening in conjunction with one another, although certainly not all 6 have to be present to successfully develop insulin resistance. But this is by no means an exhaustive list. You will notice here that inflammation is actually not called out as a distinct cog here in this wheel, and that's because inflammation will be a running theme throughout. And you'll also notice that gene mutations, I haven't specifically called out as a cog in the wheel. Certainly they should be. That's a subject really not only for its own webinar, but really for its own PhD thesis program. And for that matter, any of these could be the subject of a PhD thesis program. So what I'm going to do today is introduce these concepts, get you familiar with them so that you can be aware when you see patients, if these should be in play, you can be looking out for them and in turn take steps to address them. Let's start with Adipokines, our first mechanism today for insulin resistance. So Adipokines is another name for the chemical messengers that come from adipose tissue. It was originally thought that white adipose tissue was just nothing more than a simple energy depot, but we now know that adipose tissue, especially white adipose tissue, is an endocrine active organ and exerts many, many physiologic effects. Here are some examples of adipokines that come from white adipose tissue. And right away, the first two, you notice TNF-alpha and IL-6, both pro-inflammatory chemical messengers. So here we have the first suggestion or the first mechanism that links adipose tissue with inflammation, especially if it's in abundance. But I'm going to spend some time today talking to you about leptin. Leptin is the most abundant adipokine, and the circulating levels correlate with body fat mass. This is another principle that I'm going to make reference to later on. And one of the major jobs that leptin brings forth is to promote satiety. It tells the body that it's time to be full. If we have mice in the laboratory that are bred to be leptin deficient, we have the following disadvantageous traits. They develop obesity. They especially gain a lot of weight in a short period of time. They had a very high appetite, and hand in hand with that, a blunted metabolic rate. And then, in addition to having that very high appetite level, we have lots of consequences. We have dyslipidemia, we have high cortisol, we have low growth hormone, and of course low growth hormone directly associated with lots of adiposity, hypothyroidism, hypogonadism, and immune deficiency. So picture is worth 1,000 words, as they say. So here's a diagram that I think should hope to simplify and clarify this principle a little bit. So we start with a hormone called ghrelin. Ghrelin is a hormone that increases appetite, comes about when we have not eaten for a while and tells the brain that we're hungry. So we increase the hunger signal and we eat some food. And then, of course, with the increase of calories, we're going to do some deposition of fatty acids into adipocytes. The adipocytes are going to, in turn, release leptin. Leptin will feed back to the satiety center in the brain and tell us that we're full now, we can stop eating. So that's how it's supposed to work. So again, just taking another look at this in humans, if we look up leptin's role in our physiology textbook, we think about all the things that happen in the fed state. We're going to release fatty acids from our adipocytes because we're in the fed state. We no longer have to conserve energy. We're going to decrease gluconeogenesis. We don't have to store so much. Again, we're in the fed state. We're going to increase insulin clearance. We're going to decrease insulin secretion from the pancreas. And then we're also going to increase the net insulin sensitivity all over. And in people that have the genetic mutation or genetic defect to be leptin deficient, this is very rare, they have basically all of the opposite things happen. they increase their insulin exposure overall. Excuse me, we're going to add, excuse me, I just want to make mention. We're taking these people who are leptin deficient, and then we give them leptin to correct that problem. So now we're going to reverse insulin sensitivity, we're going to decrease hemoglobin A1C, we're going to normalize their lipids, and basically, in the final analysis, resolve type 2 diabetes. So it was suggested back in the early days of research that why don't we just give leptin to these people as a metabolic aid and as a weight loss substance? And isn't this the new wonder drug? But not so fast. So in people who are not already leptin deficient to begin with, which is most of us, you give those people leptin, and in fact it didn't alter their body morphology at all, didn't help them lose weight, didn't do anything to their glycemic control. So why not? So to answer that question, recall that leptin levels correlate with body fat mass. So here's the answer. In people with obesity, leptin complexes with inflammatory mediators. Here's another one of the ongoing inflammatory threads that it's going to run throughout my presentation today. So that leptin inflammatory mediator complex is going to, in a sense, block the net positive glycemic regulatory effects. So let's take a look at how this works now. So back to our diagram. Again, we have ghrelin coming in to tell us that we're hungry, and we consume our meal. But in this case, we're talking about a person with a large amount of adipose tissue. And when that leptin is released, it's going to bind with C-reactive protein. And that leptin-CRP complex cannot cross the blood-brain barrier. So while this is greatly simplified here just for the purposes of our webinar today, the net effect is we don't have the decrease in appetite, and we don't experience all of the positive things that leptin can do for us. That's the duality of leptin. So let me switch gears and go to our next mechanism of insulin resistance, which is a disrupted circadian rhythm. So certainly this is a problem in America. We're not sleeping very much. I would assume it's a problem all over the Western world. But here in the States, most people routinely get less than 7 hours a night. I would say they probably get a lot less than that in most cases. And as you can see here, those who get less than 5 hours of sleep per night, which again, not uncommon, 46% increased risk for developing diabetes versus 7 to 8 hours of sleep per night. So makes the strong suggestion here that one of the ways that we can start to intervene in this process is to work on sleep with our patients. And so when we think about circadian rhythm, we're not just thinking about melatonin, we're not just thinking about cortisol, but many, many body tissues have a circadian pulse, a circadian rhythm to them, and it's worth noting. Okay, so let's delve a little bit deeper here. Disrupted circadian rhythm really affects a lot of these same Adipokines that we were just talking about, and primarily let's return to our old friend leptin. Leptin levels are supposed to be highest in the evening, and I mentioned the relationship with growth hormone. If leptin is working properly and everything is in good homeostasis, it's going to promote growth hormone, it's going to promote melatonin, and promote good immune system function. And then, of course, hand in hand with that, fat burning is going to be at its peak during nighttime hours. But should we be in a state of sleep deprivation, we're going to reduce leptin levels, and not only will that lead to some of the adverse consequences we just talked about, but because we don't have that satiety signal, we might be predisposed toward late night meals and snacking, which is going to further the problem. So just by way then of summation, we're going to predispose ourselves to all of these things here in this list with inadequate sleep. Okay, the next mechanism I'd like to discuss, environmental toxicity. Just a massive, massive subject that certainly I'm only going to scratch the very surface of today. But we have these compounds in our environment called endocrine disrupting chemicals. And a lot of academic bodies, professional institutions like the Endocrine Society here in the United States have done a great job with really elucidating the problem with some of these endocrine disrupting chemicals. The problem is that it's not the province of mainstream medicine yet. It's really still, unfortunately, the domain of functional medicine. Hopefully that's changing. But what we know so far is that some of these endocrine disrupting chemicals can play the role of an obesogen, which is a term that was first coined not very long ago at all, so it just points out the newness of this field. Take a look at this list. It's really startling, to be honest with you. These are known environmental endocrine disruptors, but they're also obesogens. Take, for example, MSG at the top of the page. And then known problems like BPA, phthalates, and then at the very bottom, just is very much an abridged list, lead is a heavy metal. These are substances that can not only disrupt our hormonal signaling with lots of other consequences, but can also conspire to make us gain weight and disrupt our metabolism. One of the genes that many of us have in the wild type, so to speak, is PPAR gamma. And PPAR gamma predisposes people toward diabetes. And certain endocrine disruptors can activate PPAR gamma and create a situation where we're making bigger and more numerous fat cells. This is just one example of how this can go. So implication being, we should be doing an environmental history, we should do environmental intakes with our patients, and even if we're not environmental medicine experts, we can help our patients practice avoidance. The next wheel in our cog of insulin resistance is a subject that is close and near and dear to many of you, maternal nutrition, especially if you do any preconception care, midwifery, or even pediatrics. So if we have a situation with inadequate maternal nutrition, and when we say inadequate here, we're really talking about a low protein environment. We don't often have a low caloric environment nowadays on the average, being a rampant problem in the field of maternity care, but we do have occasionally low protein intakes. And what that leads to is a tuning of the child's metabolism to promote a thrifty phenotype as they get a little bit older. And so basically you have a child being genetically programmed to expect to be in an environment of scarcity. But of course, we don't really have in the Western world an environment of scarcity. We have an environment of plenty for the most part, and that results in a mismatch between the child's genetic expression or their phenotype and their environment. That predisposes them toward metabolic syndrome. And then in animal experiments where they've actually done this, we experience all of these detrimental effects: obesity, reduced leptin and all of the bad things that that can cause, endothelial cell dysfunction, and altered cardiovascular function. Another thing that we see in terms of phenotypical expression is small beta cell mass at birth. This also predisposes the child in yet another way toward suboptimal glucose regulation as they get older. I just want to conclude this section by making the point that it's not just the poor maternal nutrition. It's actually a range of maternal nutritional environments. And we all know that gestational diabetes predisposes children to higher birth weights. That's a known cause in many instances of increased risk for insulin resistance and metabolic syndrome. So it's not just poor maternal nutrition, it's actually excessive maternal nutrition. It's the range, it's the extremes that are the problem. Moving on to mitochondrial dysfunction. This is a very, very hot topic in the field of functional medicine. And my personal hope is that we have more widely available tests soon to assay mitochondrial health. But we know that mitochondria are very, very critical to blood glucose homeostasis. If mitochondria should be damaged via environmental persistent organic pollutants or other causes, we have decreased insulin secretion, and we have decreased expression of glucose transport proteins. It turns out that mitochondrial DNA is actually more easily damaged than nuclear DNA, and we don't have the same level of repair mechanisms for mitochondrial DNA either that we do for our quote-unquote regular DNA. So if we look at the extreme, which in this case type 2 diabetes, and we sort of start from there and then look back at mitochondrial health, it's known that mitochondrial size and mitochondrial count and efficiency are decreased. We know that diabetic patients have overall less mitochondria. It's a little bit just redundant, but to make the point there. Oxidative stress and mitochondrial damage is one of the forerunners to diabetes. So if it's the forerunner of diabetes, it's also going to be the forerunner of insulin resistance. That's my main point here. Let's take a look at a molecule called AMPK. This is adenosine monophosphate kinase. It's one of the major energy regulators in our body, and it's a major mitochondrial support molecule. So when we have a relative lower caloric intake, we know that a lower caloric intake is one of the things that has been proven to promote longevity. It's not really what we're talking about here, but in a similar vein, lowered caloric intake promotes AMPK. Conversely, an increase in caloric intake decreases AMPK. So let's start there. Also, if people who are exercising, people who are very physically active, of course, with care not to overtrain, have more AMPK. What this is going to do when we have more AMPK activity in our body is promote the health of mitochondria. It's going to promote fat burning in the body. It's also going to promote glucose burning as well. It's going to keep hunger signals in check. It's going to improve insulin sensitivity, and it's going to decrease cholesterol and triglycerides. So this is one way, just one way of many that exercise and slightly lowered caloric intake can be beneficial to our mitochondrial health. So to look at this another way, a decrease in AMPK has many indirect negative consequences. We're going to have increased body fat overall. We're going to have, as a result, increase in Adipokines, TNF-alpha, that's inflammation. Increased cortisol because fat mass produces an enzyme that makes cortisol outside of the adrenal gland. And let's take a look at what happens when we increase AMPK. We actually have some very direct benefits in terms of reducing inflammation, and one of the ways that happens is we decrease NF-kappa B. You might be familiar with this. This is one of the major pro-inflammatory pathways in the body, and when we decrease this, we have a net anti-inflammatory signaling in the body. Okay. Another major mechanism of insulin resistance, imbalanced gut bacteria. Also the subject of probably more than one PhD thesis program. But really, we're coming to understand that the microbiome is, and the successful manipulation thereof is going to be one of the futures of medicine. It's going to be the future. It's going to be one of the ways that we foundationally change our relationship between health and disease. So many of you already know that the gut is host to about 100 trillion microorganisms. And here's a fun fact. Gut microbes collectively weigh about 3 pounds. This is not a way in which we advocate for weight loss, by the way. And we're just beginning to learn about all of the metabolic functions of the microbiome, but going back to AMPK that we just discussed, gut microbe activity promotes the release of AMPK, helps in the release of certain intestinal hormones that regulate appetite and metabolism, influences satiety and fat storage, synthesizes essential vitamins. We've known that for a long time with vitamin K, for example, and also regulates the extraction of energy from food. Speaking of which, there's this quote-unquote obese gut microbiota profile, and then there's a quote-unquote lean gut microbiota profile. And the more we delve into this, the more we understand this, it may very well be that one of the things that is promoting obesity in our society is an imbalance in gut microflora. How we impact that and how we influence that, we just beginning to learn. Certainly many of us already use probiotics. We're going to have to develop a better understanding of which microbe strains to use when. That's a developing science. But certainly promoting gut health overall, which is something we're already doing, should help in our goal here of reducing insulin resistance. Now, for those of you who work actively with digestive concerns, you're probably well aware of SIBO, which is small intestinal bacterial overgrowth. And it turns out that there's a very much increased proportion of SIBO in patients who are obese. And it turns out, of course, that many people who are obese have digestive concerns. So this is another connection that we're beginning to learn more about. Certainly if we're doing digestive health, testing for SIBO with either breath test or with whatever mechanism you're using in your practice, and treating it appropriately is going to be important. We know that babies who are born vaginally are inoculated with all kinds of beneficial microflora from their mothers. And we also know that the converse is true, that babies who are born via C-section do not have that critical exposure. And by the age of 3, obesity rates in babies born via C-section are double that of babies that had a vaginal birth. So this is also something to look for in our patient's history. perhaps this would lead us to be more aggressive in terms of prevention and treatment with our patients. So here's a statement that I'm happy to make. Leaky gut is no longer a myth or exclusively the domain of quote-unquote alternative practitioners. This is something that is finally starting to make its way into the mainstream. And one of the ways that one of the pieces of evidence that I bring to you today to sort of prove this point are some publications by none other than the American Diabetes Association. And let me walk you through this here. The quote-unquote SAD diet, the standard American diet, which is a diet high in simple carbs and high fat, increases the absorption of gram-negative endotoxins, such as lipopolysaccharides. And when people have high LPS exposure, that's termed endotoxemia. So when we have high LPS, or that endotoxemia state, the LPS is binding to adipocytes, increasing adipokines, and in turn promoting inflammation, promoting insulin resistance. And to just give you a sense of the scope of this issue, the second bullet point here, in mice, the level of LPS needed to achieve insulin resistance and weight gain was 10 to 15 times lower than what was found in septic shock. So we're not talking about poisonous levels necessarily of LPS. We're talking about a low-grade, sort of chronic inflammatory state here. So again, another paper by Diabetes Care. This is a journal of the American Diabetes Association. Endotoxemia is associated with increased risk of incident diabetes. So remember at the beginning of this presentation I mentioned the 5 parameters of metabolic syndrome. Turns out that there's a linear relationship between LPS activity or endotoxemia and the number of positive parameters of metabolic syndrome. This is another reason to pay attention to gut health, as if we needed another reason in the first place. There are tests available for lipopolysaccharide. Hopefully they will be more plentifully available as time goes on. So this is something we're just beginning to scratch the surface on. I want to give you a couple of materials for further reading. The belly fat effect, written by Mike Mutzel, is a really very well-referenced resource, very easy to read, and does a great job of going into very exquisite detail of this problem. Now, we've talked about 6 causes, 6 mechanisms of insulin resistance, and certainly, as I mentioned before, this was not an exhaustive list. But what I'd like to do now is transition to some consequences, things that flow forth from insulin resistance once it's present. And these consequences that I'm going to present to you today lie, for the most part, outside the realm of just pure blood sugar dysregulation. We already know that's a consequence. But the 3 that I'd like to point out today are atherosclerosis, sex hormone imbalance, and systemic inflammation. Okay, beginning with atherosclerosis and cardiovascular disease, it's well known that type 2 diabetes is a major risk factor for cardiovascular disease, nothing groundbreaking there. But let's take a look at a little bit more about how this works. So it's not just the high glucose signal, it's the high insulin signal as well. And both of these conspire to decrease the health of our vasculature. So on the insulin side of the equation, we have a decreased endothelial nitric oxide synthase activity, and we also have the promotion of vascular smooth muscle inside the vascular wall. We know this is one of the ingredients to atherosclerosis. On the glucose side of things, we have the formation of advanced glycosylated end products. Basically, it's a stiffening of the cell walls that line our vasculature, which leads to a whole host of cardiovascular problems, not the least of which is blood viscosity, something that we're very much involved in here at Meridian Valley Lab. So by way of bringing this in a little bit more into the world of reality, patients with insulin resistance were shown to have significantly increased aortic stiffness. And it wasn't just insulin resistance, it was also age, circumference, and triglycerides that impacted aortic stiffness. But of course, we've already discussed how that's kind of all part and parcel of the same picture. Age, not so much, but certainly it's the point here is that insulin resistance, even after we adjust for fasting blood glucose, cholesterol, and that includes LDL and HDL, blood pressure, and BMI, this relationship held to be true. This is one of my favorite news clippings. It comes from UCLA from the year 2009. You can see the headline there. Most heart attack patients' cholesterol levels did not indicate cardiac risk. Nearly 75% of patients hospitalized for heart attack had cholesterol levels that would indicate they were not at high risk for cardiovascular events, based on the current, at that time, national cholesterol guidelines. So when I'm presenting some of this information to groups of people in live audience, I ask the question, okay, what do you think this paper concluded? Well, I'll just go ahead and give you the punchline, and that is that they concluded we need to make our lipid guidelines more stringent and more narrowed, more strict. And of course, that's what they did last year here in the States. But from a functional medicine point of view, we know that while cholesterol is important, it's not the only thing. It's just one piece of the puzzle. It's not the whole puzzle. And what I'm suggesting today is that blood sugar dysregulation may contribute more to cardiovascular disease than just high cholesterol alone. Okay, we've talked about how inflammation is very much an ongoing theme that runs through all of our causes of insulin resistance. It's also a consequence. So we have inflammation begetting insulin resistance, leading to more inflammation. It's a vicious cycle. I'd like to just summarize a few of these relationships for you here, and I'm going to take this step by step. When I'm done with the slide, you're going to see kind of a map, and it may appear a little bit overwhelming. But let's break this down just piece by piece, because the main take-home here is that inflammation is something we need to be cognizant of at all times. So if we begin with our high insulin signal, we know how that increases the size of the adipocytes. And it follows that that increases free fatty acids, can lead to dyslipidemia and inflammation. Secondarily, we know that leptin levels correlate with body fat mass. One of the consequences that I didn't mention explicitly was a downregulation of T regulatory cell function, and that also can contribute to inflammation. There are other inflammatory cytokines, or Adipokines, TNF-alpha, IL-6, CRP. Those directly promote inflammation. And then finally, I hinted at this earlier, the more adipocytes we have, the more body fat mass, the more we're going to make cortisol from an extra adrenal source. And it happens with this enzyme called 11-beta HSD1. And this is something that if you have looked at our 24-hour urine hormone panels here at Meridian Valley Lab, you're very familiar with already. We know that the more cortisol we have in circulation, the more we're going to be predisposed toward increased visceral adiposity. In turn, that leads to more inflammatory Adipokines and more inflammation. So many ways that inflammation can come about as a result of insulin resistance, and in turn, several ways that we can intervene. The last consequence that I'm going to present to you today of our abridged list has to do with sex hormone imbalance, and I'm going to focus just for a moment here on men's health. And one of the consequences we have here is the more fat mass we have, the more aromatase activity we have. And aromatase is the enzyme that transforms testosterone to estrogens. And it's something that really causes a lot of problems as men get older on the average. So to illustrate this, I'd like to show you a few ways that this works. So with a high insulin signal, we have increased visceral adiposity. There are many steps in that chain. I'm sort of jumping ahead there, but we've already looked at this relationship. And from that increased visceral adiposity, we have increased leptin and Adipokines. One of the effects of that is to influence the pituitary, and it's going to diminish the LH pulse amplitude. Luteinizing hormone, or LH, is one of our main signals that leads forward to the testes to make testosterone. So with decreased LH in circulation, we're going to have decreased testosterone overall. At the same time, and in parallel, we have increased aromatase enzyme activity, and that's going to increase estrogen. So we have a net decrease of testosterone and a net increase of estrogen so far. Now, if that wasn't bad enough, one of the things that happen from there is we have a resulting increase in lipoprotein lipase. This means more dissemination of free fatty acids, increased triglycerides, and then in sort of feed-forward fashion, we have more deposition after a while back into the adipocytes, and the cycle continues. And maybe you've noticed as I've been talking, our gentleman here in the middle of the slide has sort of become more and more portly around the middle. Our medical director, Dr. Jonathan Wright, points out that in his experience, up to a third of patients who seek testosterone replacement may have insulin resistance. So this is a major, major mechanism that we need to contend with if we're going to do men's health. As we come to the end of our presentation today, I'd like to just summarize in brief what we've talked about. So insulin resistance, it's, as you've gotten the sense today, not only is it multifactorial, but it's a phenomenon that extends beyond the simple overconsumption or type of calories. The whole model of calories in, calories out certainly is not the major prime mover in terms of insulin resistance. And if we keep in mind at least these 6, if not more, mechanisms that underpin insulin resistance, then I think we're going to have an easier time doing functional medicine, doing natural medicine, keeping in mind intestinal bacterial imbalance, Adipokines, maternal nutrition status, the health of our mitochondria, doing environmental toxicity intakes with our patients, and looking at their sleep cycles. And then feeding forward, once insulin resistance is present, we need to be aware of the risk, I should say the increased risk of poor vascular health and atherosclerosis, sex hormone imbalances, and that certainly is not solely the domain of men's health, but it was a powerful thing that I just wanted to show you today. And then, of course, more inflammation. So hopefully today I have set the groundwork, I've set the table, so to speak, for our next module, which is going to be in 2 weeks' time, assessment, testing, and monitoring by my colleague, Dr. Pushpa Larson. As we have these foundations now in place, we're going to move into the realm of what do we actually do about this. And it's going to start with testing. So now, and if you haven't already, please be sure to sign up for parts 2 and 3, and that can be done at meridianvalleylab.com. The webinars after broadcast will be available for you to view also on our website, meridianvalleylab.com. Okay, so now I'm going to take some questions. Of all the mechanisms I discussed, is there one or more that myself as a practitioner think is most important? Or what would be my priority in assessing insulin resistance with the patient? That is a really, really good question. Which one of the 6 that we've discussed today stands out? It's hard to really name one that's more important than another. Certainly, I think it's about taking a look at each patient as an individual, doing an individual assessment, and treating them where they're at. But I think certainly looking, for example, at their sleep, not that that's necessarily the most important cog in the wheel, but I think more than any of the other ones exemplify how we need to take a step back and take a look at mechanisms that don't have anything to do with the type, what a person is eating. And certainly I don't mean to minimize for a moment how important good nutrition is, but certainly it's a way that we can be very effective with our patients by thinking a little bit outside the box. What is the best way to evaluate insulin resistance? I look at hemoglobin A1C and fasting insulin. Do I recommend anything more than that? This is a very, very good question that my colleague Dr. Larson is going to answer very thoroughly in 2 weeks' time. Hemoglobin A1C is a start, and certainly I didn't mean to imply that it was without utility. Certainly it's a good screening test, but it doesn't tell the whole story. And similarly, fasting insulin doesn't tell the whole story either. We've noticed here that both fasting insulin and hemoglobin A1C can be normal even in cases of profound insulin resistance. And the reason for this is because the body may be able to produce a very, very high level of insulin in a postprandial state to, in the end, dispose of all that glucose, such that hemoglobin A1C is normal. If the glucose is being well disposed of, hemoglobin A1C is going to be normal. Moreover, if a person is able to return to baseline very well from that very, very high postprandial hyperinsulinemic state, then fasting insulin is also going to be normal. So my colleague Dr. Larson is going to talk about this in more detail, but very, very good question. Let's see, next question. Isn't it true that thin people can also have insulin resistance? Yes, absolutely true. Also sort of a known, very, very well accepted phenomenon that also flies in the face of calories in, calories out. It's something that we should be aware of and shouldn't close our minds to as we're working with people. Okay. Another question about how to evaluate insulin resistance, better ways to do this. By way of preview, we here at Meridian Valley Lab work with something called the glucose tolerance insulin response or insulin resistance test. And what this is a variation on the theme of a 2-hour oral glucose tolerance test. And instead of just measuring glucose or just having the test go for 2 hours, we extend the test to 4 hours and we measure insulin levels alongside glucose. And we do this at fasting and then half-hour post-glucose drink. We do it at 1 hour, 2 hours, 3 hours, and then up to 4 hours. And traditionally, this has been a venipuncture test, but now, and we're going to be talking about this more next module, we're very happy to announce the release of a blood spot version of this GTIR test, which basically means that if venipuncture is inconvenient or contraindicated for whatever reason, you now will be able to assess your patients for insulin resistance with a simple blood spot test. We're very excited about this. We're going to talk about this more in 2 weeks' time, but I just wanted to answer this question today. Looking at postprandial, not just glucose, but also insulin levels, is really the only way to definitively diagnose insulin resistance. And then last question here, can I get a copy of the slides? Yes, you can. We'll make those available. If you email our customer service department at info@meridianvalleylab.com, we can make these slides available to you. I mentioned that the taped recording will also be available at meridianvalleylab.com. With that, thank you so much for your kind attention today. It was a pleasure to spend the last hour with you. And I just want to make mention, in case I wasn't very explicit, that our glucose tolerance insulin response test, both in venipuncture form and in blood spot form, are available today. And my colleagues and I here at Meridian Valley Lab, one of our major functions is to support you. When you get your results back, call us up for a no additional cost consultation about your results. We talk about the results in detail. We talk about your patient. We talk about treatment possibilities. It's a fairly open-ended conversation. That's one of the ways that we are here to support you. Thank you again so much for your attention. It's been a pleasure speaking with you today, and look forward to speaking with you again in 2 weeks.